I'd like to ask our three speakers to come up to the front. You almost escaped, but not quite. Oops, I don't want to show back up, right? So tell me how I get rid of that.
Blank?
Yeah,
Do you want
blank. Let's do blank.
Blank is good.
Yeah, blank is good. Okay. So everybody take a deep breath. We have some time for questions. Yeah, that was a lot. Very, very rich. Three very rich presentations. I'd like to, we have about an hour before we have a little time for relaxation and getting to know each other better. And we had planned that time to be more for open discussion, but I'd like to, at least initially, open the floor to questions for the three speakers about their presentations. I think all three of these presentations highlighted quite clearly that I would venture even to say that just about all interventions have both health and financial protection effects, but to differing degrees. We are clearly at an early stage of understanding what those are, and not only that, but even how to measure them, and agree on how to measure them. And I guess my last general observation would be what often happens, especially in economic studies, is that the frame of reference, the degree to which you expand or contract the frame of reference to the individuals, the communities, the society, has a great deal of effect on what you find and what you conclude. So we should be careful always to be comparing apples with apples if we're going to draw conclusions. So let's start with some questions from the audience.
Yes, Alex Verhoeven from the LSE. I have a question for Charles about one of your results. So as I recall, the deaths averted from pneumococcal vaccine, or cases averted, which is roughly similar, right, and by an improvement in antibiotic treatment were roughly similar, number of deaths. But the financial burden impact, you said, of rolling out the vaccine, improving vaccine coverage, was it prevented fewer cases, right? It was more beneficial to finance antibiotic, right, treatment in terms of finances than deaths. That was early on, but then later you showed this case in which the number of deaths averted through pneumococcal vaccine was greater, right? But the financial burden averted by paying for antibiotics was greater. I don't understand how that can be the case. If you avert one case of pneumonia, a case that, let's imagine, at a certain rate would have led the person to buy treatment, then for every death you prevent from pneumonia, you also are, or every case of pneumonia you prevent, you're equally likely to prevent expenditures. So how can we have this divergence which you showed? So it's just a question of understanding. How can we have a case in which it's much better for health to vaccinate people, but much better for averting financial burdens to provide antibiotics? I'm not understanding how that's possible.
Thank you. I think that's good. Charles, can you make a note of that? Let's take a couple of questions so we give people a chance to speak, and then we'll come back to the panel. Please.
Hi. This was a terrific panel.
Introduce yourself.
Sure.
Please.
I'm Brendan Saloner. I'm a postdoc at the University of Pennsylvania. So a general sort of move that's made here in the United States against reducing toward increasing cost sharing on especially moderate income households is that that makes them better consumers. It gives them some skin in the game. So there's this sort of moral hazard argument that on the one hand, you're increasing their financial risk, but on the other hand, you're making them a little bit more sensitive to costs, and that could cause them to think twice about consuming some medical care that may not be of high value to them. And so, this argument maybe has less appeal for the very poor, but certainly as you move up in the income distribution, you can understand And when you have, and as you try to expand that benefit package in a universal coverage scheme, and more kinds of things are available to families, you can understand the appeal to that kind of an argument. So I wanted to get a sense from the panelists whether you thought that, one, this was a compelling argument, and two, whether you had thought about how this might have implications for how you structure a benefit package, whether you lower cost sharing on a premium that a family pays versus lowering cost sharing at the point of service.
Okay, thank you. Let's take one more.
Question about the welfare benefit of insurance. I think it's very important to realize what several of you have noted. Paul Menzel from Pacific Lutheran University. Very important to recognize the financial protection benefit of insurance, not just the health gain from the treatment or prevention covered by insurance. Is there not another welfare benefit of insurance, which is not financial protection, achieved when one actually averts a cost later because one does get ill and cost of treatment is saved and one doesn't go into poverty or bankruptcy, but also the welfare benefit of security, which I think is one of the great attractions to many people in the population. I haven't thought at all about the relative importance of security as distinct from financial protection, as you defined it, as a value of insurance in relatively wealthier countries compared to relatively poor countries. Any
Good.
observations on that?
Thank you. Let's take a pause there and now give our panelists a chance. Kjell Arne, you take the first one.
Yeah.
How can you possibly have different results for two different kinds of interventions, if I understood the question?
Yeah, that's obvious. You can always have at least two different results for two interventions. I admit it was a bit confusing on the slides because I thought it would be important to present the absolute numbers. So that was what most of the bar plots were based on. But then I also thought it's also important to realize that we have some budget constraints, so therefore I also looked what you get for a $1 million. So that was maybe why it can switch a little bit. But it's also important to, an important assumption we have in the model is that we don't get any financial protection for scaling up treatment for uncovered patients because they don't buy the treatment today. They can't afford it, or they don't have access to it for a reason or another, but they will get the health benefits for it. That's what the assumption is.
Was there also some influence of the fact that the people who get treatment are people who are sick, and the people who get immunized wouldn't all get sick?
Yeah, that's also influencing the results a lot, and that's what is interesting with comparing the two types of intervention, prevention versus treatment. Right. Because you have to close to, I don't know the proportion of patients that seek care for pneumonia that actually will receive the benefit, but when they receive the benefit, they will have a huge effect. The relative risk reduction is 70%. So we're talking about a much smaller population we're dealing with in a model than about the preventive case. Then we are giving vaccines for all babies.
Dean, you wanted to comment on this?
It's a good question, and I think the contrasting example of rotavirus vaccine and the treatment of diarrhea in a district hospital in India illustrates the point you're raising, because there the reduction in incidence of diarrhea and therefore the reduction of not only hospitalizations but expenditures on hospitalization and the financial risk that households bore beforehand of that gave a greater degree of financial protection benefit to the immunization than to an insurance against treatment program. And that's because, I mean, these are, in both cases, highly linked interventions. And the question of how important the crowding out of treatment costs will be is clearly differs from country to country and condition to condition.
Okay, we'll leave the rest of that one until you wanted to add to that. I was going to leave the rest of that to
no,
the cocktails, but
question.
go ahead. Do you want to comment on that? Or shall we turn to the moral hazard question?
Yeah,
Okay, go ahead.
if you go like this.
Whatever.
Yeah, so the question is, of course, a good one, but it really depends on the context, as you already implied in your question. If you're currently in a world, which in many sub-Saharan African countries we are, of underutilization relative to some normative standard of need, then we do not want a co-payment that further reduces utilization. We would actually like to pay people something to utilize. And if we are in a relative to a normative standard, and if we think that's where we want to be, right? So you said they become better consumers, but that's better relative to what you think they should be consuming, not what they themselves think. They're consuming precisely what they think they should be consuming under their incentive structure they're facing, health detriments, the niceness of talking to a doctor, the pleasantness of wasting some time in an area waiting for the doctor. So all of these things would factor in here. But relative to your criterion, they become better consumers. And if we are in an overutilization world, then we might want to reduce, due to a co-payment, of course, utilization. So in these settings, I think that we are looking at these extremely deprived settings with high levels of underutilization. We do not want co-payment.
Any other comments on the moral hazard question?
Just to give a different example from the United States than yours from the University of Pennsylvania, where I'm from in Seattle, there's a Kaiser-like HMO, Group Health, and even for their very high deductible plans, they have zero copay for the first 6 visits per year to primary care physicians. So they think that people don't have their incentives right, that they are overly sensitive to the cost of those payments if they were having to pay them, and therefore are not getting in to see the doctors early enough. So the high deductible plans include 6 free visits. So that in kind of incentive structure, their conclusion, let's put it this way, is that moral hazard is unimportant as an issue here.
Okay. And let's just give you all a chance to comment on this question of what's the value of the security aspect of insurance differentiated from the financial risk aspect, if one could do that. Dean, maybe you want to take a shot at that one.
I think, Paul, we're trying to get at that. I don't know if Mark Flurbe is in the audience. I haven't met him. I've read a paper of his recently that would have gone slightly in the other direction, I think, of saying it's really mostly about the ex-post income level outcome. My own sense is that the security is provided from not having to bear the risk, and that's in estimating the value of the premium you would pay, you're getting at the security value.
Right. Anyone else would like to take a shot at that question? Okay, let's move on and take another round of questions.
Richard Cash from PHFI in the School of Public Health. The consequences of infectious diseases in any country, and especially in India, are very much affected not just by whether someone is treated, but how they're treated. As you may know, MDR-TB is now becoming a huge problem in India, and the cost of MDR-TB is about 100-fold that of standard DOTS treatment, and XDR-TB, which has now appeared in a number of cities, is beyond comprehension in terms of Indians' budget. So that if patients are treated through the private sector, which is what you've implied, the chance of not following through on these patients, which the follow-through is terrible, is increased greatly. Therefore, the ultimate cost is far, far greater to the society than if DOTS is given through a much more organized and a free system. And I don't think that you consider this in your in your model. That where you have a problem with MDR-TB, it basically represents a failure of a treatment system. And the cost far exceeds those kinds of costs that you were looking at. So is it ethical really to go through an economically, what may appear to be a sound policy, but what will end up causing much greater risk to the population and much greater cost? I guess that's the question for you, because within Bangladesh, which is I'm much more familiar with, the presence of MDR-TB is much lower, and it's done through a system of community-based care. Which leads me to another question to Till. Why are you still having people come into clinics from great distances when in fact this could be delivered at the home level? So you've got artificially high costs in a system that, as far as I'm concerned, is terribly outdated. Thank you.
Thanks, Richard. Let's hold those. Let's take another one or two questions. Norm?
Yes, this is two quick questions. One is, how sensitive is the analysis that Shalarna and Dean were giving to social mobility? Because if people are moving out of poverty into other groups faster than you would think, that instead of their not being able to buy something, they would be able to buy something if they moved out. And would that change the issue?
That's one.
That's one. Okay. The other question is, I'm a little puzzled by Till's focusing on the indirect effects of the economic gains that would come from treating HIV patients, because there's no surprise that there are economic effects. The real issue is the ethical question about whether we should examine them or not, or whether they're relevant to the consideration of the return on the public investment.
Okay, thanks, Norm. One more. And I would like to encourage, just if I may, I'm going to give the panel a chance to respond to these, but I'd like to also encourage people to start thinking about more general comments and discussion, which we want to spend about half an hour before we break. So not everything has to be questions to the panel.
Okay, so I'm Anna Bersalas. I'm a Takemi Fellow from the Harvard School of Public Health. I was wondering about how we can compare the financial effects and the health effects of different interventions, so malaria and HIV, pneumonia and HIV. And the question just puzzled me, yes, because some I think Till talked about that, and someone else talked about that HIV expenditures, for instance, were not impacting other healthcare expenses, and but these expenses could be used for other interventions for other diseases. So how do we choose? That's my question.
All right, good question. Let's turn back to our panel. I don't even remember the questions anymore, but Richard's two questions, I think, for the first.
I'll answer, I'll answer Norman's questions about social mobility,
Okay.
because that's an important point we need to include in the model and look more into. Yeah, thanks for the tip.
People don't hold still.
But there is, so the only mobility, so the question is, what mobility can you achieve in a year? Because we have, or 5 years, that's the assumption for the model. So there are some limits to how rich you can get in a year or poor, but so the mobility we allow for is the out-of-pocket expenditures and how that influences income. But yeah, so but we will look into that, and yeah, how to compare the two benefits. That's the question.
It's always been a big question.
Any answers to it? It was interesting. I presented this on a Monday meeting before I went here, home in Bergen, asking the people in our research group this hard trade-off, financial protection or health gains. And the funny thing was that the discussion sort of tended to deviate away from that hard question, and they wanted to focus on problems in the model. So I hope we can discuss how to handle this trade-off. Yeah.
Okay. The MDR-TB question, any comment?
Yes.
Now I remember the questions. Go ahead, Dean.
Yeah, good question, Richard. I was commenting on these issues in a presentation at the World Bank, and World Bank manager made the observation in a slightly more general case that one of the virtues of public finance was by underpricing private finance and therefore crowding out private provision, one might well be improving quality quite substantially. Now, what she was referring to was basically quack treatments and the generally poor quality. But I think your point is a version of the same one, that if, in fact, the public sector is dealing better with treatment and therefore reducing the probability of evolution of MDR-TB, that a benefit we should explicitly be considering then is the quality improving benefit in that dimension of crowding out private provision.
Till, you want to comment on the
Yeah,
delivery
I have,
of
a comment
ART?
to Richard's, the outdated model of delivery, so I completely agree. There are many simple things that we could do to make life better for people. One includes these treatment clubs that Mozambique is rolling out, the Western Cape in South Africa, where one person goes to the clinic and then takes home to their geographic communities treatment for everybody who is accessing treatment. Of course, that requires disclosure. It requires some community mobilization around these treatment clubs, but that's potentially a very good model in settings where the transport costs to ART are high and a burden on households. Another very outdated model is the lack of a scheduling device. So people come to the clinic every day and then on average wait a few hours until they can have access to a doctor because there is no prioritization. Who comes early gets to see the doctor early, who comes late gets to see them later, or the nurse or the ART counselor. If, for instance, people with early first letters in the alphabet came earlier in the day and those with later letters of their last name came later, then probably the average waiting time could be simply reduced by such an intervention. And regarding the challenge that Norm posed, is this trivial? Why are we looking at it? We are expecting positive benefits. Yes, we are expecting economic benefits for the individual patient. It's not trivial, I think, at the level of a community, and becomes quite complex. David Bloom has an early macroeconomic paper where ART was good for economic development because people die and now the remaining wealth is spread across fewer people, increasing per capita income. So this
ART
measure
was
of economic
bad
development...
ART was bad for economic development.
HIV was good for
for it,
ART,
yeah,
and ART then as a compensatory device would be bad for the
Right.
economy. And I presented similar results today in Paul Campbell's South African group, and precisely that question came: is it really good that we are keeping people in this group of people where unemployment is extremely high alive? Doesn't this now generate higher unemployment in the future? Because this group that previously died is now still there to demand jobs, and is it a net loss for the economy to keep people alive in the productive ages? That was one of the questions that came back. So it is actually very good to show that the net community benefit on employment, net of these reduction effects in the denominator, is still positive. That is not a trivial finding, and I think an important finding to make, because very plausibly it could have been the other way around. By keeping people alive, we are reducing this crude measure of economic welfare, unemployment rates, increasing unemployment rates. And the story goes here, of course, that by keeping people alive, we're keeping human capital alive, we're keeping entrepreneurship alive, we are ensuring that firms do not lose people they have trained for a long time, now rehiring someone into a position where someone has gained experience over many years is costly for the economy as a whole. That's a deadweight loss. We need to train this person. We need to, this person needs to acquire firm-specific human capital. So those losses are probably partially what explains that the net employment benefit of ART is positive. And you had another question, Norm, or related. Is this a question we should be asking normatively, or is there a primacy of health and the economic considerations should be left outside? Now here in this session the charge was to look at the financial burden to patients and financial risk protection. So in a sense that question is already taken away. We are now considering these financial burdens, and then I think it is relevant to look at compensating effects if a household is better off and has higher ability to pay for those burdens if we worry about them.
Okay, thank
Maybe
you.
not satisfying.
Shall we move on to another round? Gita?
Thanks. I have a question for
No.
the last speaker, but I have to say something you said just now sort of made me, something about it that worries me very deeply. Should we be, is that where we should be going? Because in terms of ethical...
Can you clarify what it was
Yeah,
that worried you
I'm
deeply?
coming to it.
Okay.
In terms of ethical discussions, we have had at different points these questions of, you know, is it better for these children to survive or not survive? I mean, given, it's a question of the kind that it seems to me if we go there as economists, it's a deeply slippery slope. There's something about it that just I find stomach churning in a very deep way, and I have to state that. I don't have an alternative for what you do. I just think we shouldn't go there.
So I did not endorse that we
No,
should
I
go
got
there
it.
normatively. I offered it as a response to Norm, who challenged me in saying this is trivial. We are not even interested in it. We would have expected it. So I raised this issue as a response to the objective question, is it trivial or not as a normative endorsement that we should be going this way. I would agree, it's a very difficult question. The economist might argue economic benefits will increase our future purchasing power for other healthcare that keeps other people alive. So it is relevant because it is directly, if we declare health to be the primary good, the one good we care about, then instrumentally we must also care about what achieves a disease reduction and a health gain.
I know, and I suppose that's why I'm a terrible economist, because I gave it up.
There might be other bad
for-
economists here also.
Because there's a lot of other people that I could think of that one could do away with and probably live happy. All of us could live happily ever after, I suppose. I just find it very disturbing for us to be even having that conversation. But my question before this came up really was about the way you measured these spillover effects. And I'm wondering whether, in fact, the way in which you talked about it, which was in terms of what happens to the life expectancy, is the appropriate way of looking at the possible spillover effects. Because the spillover effects that I've heard of have really, there's whatever one spends on, there's something else in a resource-short situation that one is not going to be able to do. But in this context, the spillover effects that people typically talk about in the context of spending on ARTs or on HIV treatment in general is the amount of additional things that typically go into the setting up, the creation, the creation of infrastructures, all sorts of things, which typically don't get costed, and certainly don't go into, certainly not getting picked up in a measure which says, look, nothing happened to the death rates in the other group. And
Sure. So I would argue that death is a very important outcome, but we are making no claim here about other things. So there could be spillover effect that we feel are detrimental, that we are not capturing, right? But life expectancy, I think, is a very good measure because it captures everything that goes sort of in that final outcome in health, and it is good to show that there's no detrimental effect. I think that is important to show on people who are not benefiting from this program, not directly benefiting. That for them, net, there is no loss, which we might have worried about. It might have led to massive increases in maternal mortality, and we would have picked that up in our measure of life expectancy. So it's a net measure, and that's also a critique, a methodological critique. There are many simultaneous effects going on here. Compositional changes, those not dying of HIV-related causes can include HIV-negative people, but also, of course, those who are now benefiting from ART and are being kept alive by ART. And these compositional effects we cannot causally disentangle from secular trends and from the spillover effects we would initially have worried about, which is a crowding out of the ability to deliver life-saving interventions to non-HIV infected populations.
No, fair enough, and I won't carry on. But I just think that there's probably more, you would find more spillover effects within the margin of just looking for who might be dying because you're spending on the ARTs.
Right. There's an infinite increasing function of potential papers on spillover effects.
Good afternoon. My name is Werner Soers from Antwerp Institute of Tropical Medicine. When this session started, the chairman promised we would talk a bit more about ethics before cocktail hour. That woke me up, and I'm very glad we are starting to do that. Peter also asked us to question a little bit what would be means and ends, and he even came to the questioning if universal health coverage itself would be a means or an end. I will try to give a very short answer on that last one before coming to the ethics again. I would argue that, based on ethical considerations, above universal health coverage is still another end, and that is precisely equity in health. And that equity in health is something we failed about a lot over the last 3 or 4 decades, which is strange because we nearly had the policies in place. Equity was extremely central in the concept of primary healthcare in Almata. But to use a terminology which is very often used here in this room today, we crowded it out with primary healthcare, with selective primary healthcare based on cost-effectiveness analysis. Equity was also rather prominent in the Millennium Declaration, but it was totally absent in the Millennium Development Goals, where we are measuring country averages, where we can reach improvement in these country averages, even while raising inequity. I'm a bit afraid, after hearing the actual presentations on extended cost-effectiveness analysis, extended as they might be, I still think they're quite limited, quite partial in modeling the real world, that if we take that as a first step toward universal health coverage, that we in the world are in big problems for the next decades.
Okay, thanks. I'd like us to take a couple more comments now and give people a chance. There's a long line, and so please. And then we'll come back, give the panel another chance to respond, either to questions or to comments.
Thank you. My name is Marc Fleurbet. Before asking my question, I wanted to make a comment on the value of security. I think it's a very good idea, actually, to compute the value of security. What I would object to
Mark,
would be
could
just
you
to...
tilt the microphone
right,
up a
I
little
was
bit?
trying to do it, but yeah.
Yeah.
What I would object to would be just to do that and not look at what really happens to people at the end of their the end of their life, right? So it's not just the value of security that counts for them, it's also what really happens to them. And so it's good to take account of both. As I understand, you do both actually, because you also look at the number of cases of averted poverty or averted deaths, which is really the exposed distribution. So I don't think we really disagree on that. My question was about the definition of extended cost-effectiveness analysis. I had the impression, by what you said, that it was broadening the scope of the instruments and policies that were the subject of the analysis. And that reminded me of what we heard about Cuba earlier this afternoon, that the definition of health intervention was much broader and covered things like housing policy and so on. So I wanted to hear more about that, whether that was the right understanding. And I was also interested in the fact that equity weights were considered for introduction in this context, which means that it's not just the production of health that is measured, but it's the welfare impact of this production of health that is somehow taken into account. So that seems to broaden not just the scope of the analysis, but also the consequences that are taken into account. And my last comments in this line is my last question would be, how far are we remaining from cost-benefit analysis? So are you thinking of going in the direction of cost-benefit analysis and looking at the trade-offs between health and other uses of resources? Thank you.
Okay, thank you. Let's.
Yukiko Asada, Dalhousie University, Canada. My comment question is also related to the extended cost-effectiveness analysis. I think it's quite useful to see that an impact and in cost, so both cost and benefit effectiveness, both we look at not just the average, but in a different segmental population. And I take it both of you looked at an income, but we could do, if data are available, for different groups like a rural area and an urban or whatever. So I think that's very useful. And then I assume that you made a bunch of assumptions, probably more than regular cost-effectiveness analysis, and you needed to conduct a lot of sensitivity analysis, more than you could possibly present here. So my question is that extending your final result to different segmental population, do you think that sensitivity analysis becomes much more important, or it's just the same thing, you just have to repeat different segmental population? And then I'm kind of assuming probably it becomes much more complex and the sensitivity analysis is more important. Then in your analysis that you probably couldn't present today, is there anything particularly you thought might be very important that then we have to look into if we extend our work to this direction? So I think Norm's question of social mobility is probably one of them. And then I was thinking that I don't know if we still have a debate that even not looking at the distribution, just one number from the population, should we use a discount rate or not? And then discount rate is originally because we think about future differently. And then literature suggests that if your education level is different, you discount differently for future. So should we introduce different discount rate? So it gets fairly complex, but if any thoughts around that would be great. Thank you.
Can we hold on to that for another minute? More complexity?
Yeah, more complexity.
Everyone's been sitting very patiently there. People want to speak, so let's give them a chance.
My name is Mariska Meurs. I'm working with a Dutch NGO working on global health advocacy. I don't have a question in particular to these speakers, but more a general question and comment. We've been talking here about the ethical dilemmas of moving towards universal health coverage in low-income countries, which have limited resources. But only a few people have touched upon so far the underlying causes of this resource scarcity. And I think that's something that we cannot avoid when we're talking about ethical issues. It has been mentioned that public funding is very important to move towards universal health coverage, but all over the world public budgets are under a lot of pressure. And partially this pressure is caused by global mechanisms that are beyond the control of individual governments. And I like the way in which Ole formulated some questions this morning to illustrate the linkage between universal health coverage and financing and ethics. And I think in that same way, we can pose questions that illustrate the linkage between global policies and UHC and ethics. And we can ask ourselves, is it fair that low-income countries over the last 10 years have lost $5.9 trillion through illicit outflows of money? Or is it fair that multinational companies, by shifting their profits to subsidiaries, can avoid paying taxes and thereby reduce government's possibilities of raising enough tax income to finance their public health programs? Or is it fair that the European Union is pressing India to go beyond TRIPS? And is it fair that we enter into investment agreements, as Gita mentioned this morning, that are allowing international arbitration? And, well, I don't know why we are avoiding these questions, probably because they are so hard to solve. But, you know, there are elements or partial solutions being thought of, and this needs a lot of political pressure. The solutions are not technical. I think we need to talk about the politics, about the ethics, and not forget that you should not take this resource scarcity not for granted.
Okay, thank you. Well, thanks to you, those issues just came on the table, so that's good. Let's go. One more.
Okay.
Yeah, why not?
I don't know how you guys are going to deal with all of this. But
They're going to ignore the ones they don't want to answer.
Chilani asked about how you're going to compare these two different axes on those kind of two-dimensional cost-effectiveness analyses, where there's a scatter plot of different effectiveness. And I think that I took the liberty of taking a couple of photographs of people's slides and had a look at the numbers and so on in some detail. And at the end of my talk tomorrow, I might get a hold of some of these slides and just give a quick demonstration of this. But for plausible indifference curves that you can draw on there, so effectively you can draw these straight lines with this kind of slope across the thing. And for plausible different steepnesses of that slope, I couldn't see any plausible lines that you could draw which would actually change the ordering all that much from just a deaths averted ordering. So because I can show that in some more detail, but in some of the cases, I mean, in Dean's slide, the measure of financial protection was cases of poverty averted, and the other one was deaths averted. And if you think it's at least as bad to die as to go into poverty, then that gives you a certain kind of line on that. And that line's steep enough that it ends up not looking very different from a vertical line, which would be the... So it's interesting. I mean, this has been my hypothesis in the case of when we try to extend the cost-effectiveness analysis in poor country settings, that the financial protection will end up not changing the ordering much, at least among the most effective interventions. It might change it among the less effective interventions. But there's other hypotheses out there as well. Some people think that financial protection actually is more of the major aspect than the health benefit. And so I think it'll be really interesting to see, even with some early ECA data, what that picture starts to look like and whether my hypothesis is correct or not. But I can give you the visual aids.
Can you introduce yourself briefly?
I'm Toby Ord from Oxford University.
So we can find you if you publish those graphs that you photographed.
Cheers.
Okay, let's give these guys a chance. Related, please, go ahead. On the default side, we stand with the people here, so.
I'm Monica Magalhães.
Introduce yourself, please.
I'm Monica Magalhães. Can you hear me?
No, we can't.
Can't hear you.
I'm a health policy and ethics student here. And I was also wondering about this measurement of financial protection being cases averted of crossing poverty line. It works very symmetrically with debts averted, but then I guess that that measurement's not sensitive to the magnitude of the impoverishment, and it would not, it just wouldn't count other people, suppose, that were very poor already to start with, and through borrowing, which your model allows, then become even poorer. I think that wouldn't appear as financial protection at all.
Yeah,
And
no, good.
I don't know if
Those are clear. Yes, your question's clear. Good. Thank you. Let's give the panel a chance to come back on any questions they want to answer and ignore any ones that they don't.
Yeah, can I start?
Sure. Eager.
No, I've been sitting here taking notes. Thank you for all these good questions. We should really debate this. So how long have you got?
Which one?
All of them. Well, I'll try to swipe through the questions here. The last question is a really good question, and I'm really concerned about it as well. Do the measures of financial protection actually capture the size of impoverishment that people risk ending in? And it actually, it does. Because you see from my slide that if you compare the net household expenditures averted, which is just counting up the dollars that people in the different income groups actually avoid spending. That's an absolute measure of the magnitude of the financial burden. But when we then apply the utility function and the certainty equivalent, then there is a relative risk aversion coefficient there. So then, because the absolute size of expenditures are almost the same, close to the same across income groups. But in relative terms, this will be much more substantial for poor people. So therefore, since we apply constant risk aversion across income groups, therefore the financial protection will be much higher for the poorest groups. So it is incorporated into this model, and I don't agree that it's insensitive to it. Okay, so yeah, okay, so it's not directed to me. So then sorry. Okay, but yeah, because we have two different measures. Because he's using, I'm using financial protection. Yeah, so then, well, then I don't, maybe I agree with you. I'm not sure.
Okay, good.
But also to, there were lots of questions. To Mark, so what is an extended cost-effectiveness analysis? Maybe Dean and I have different perspectives on it, but I sort of see extended cost-effectiveness analysis to, well, now it's possible to extend it to all kinds of dimensions that is ethically relevant. And then financial protection is relevant. But I also think it is important to try and incorporate the ex post outcomes into such an analysis and not limit it to a utility function looking at the financial protection as we do. But I think we also need to look at the ex post distribution and expected utility across individuals in other ways. But it's quite early in the phase of these ECAs. And also there were some questions about, well, there are huge assumptions in the models and we need a sensitivity analysis. Yes, I definitely agree. And I've had weeks where I regretted I did this in Ethiopia and not in Norway, where we have the beautiful data registers. But still, I think it's important to do it even if we have missing data. So we should get more data and we should get better methods for handling missing data so that we can carry on doing this. So that's my brief answer to that. But the interesting thing, even if there are lots of uncertainty in the model, what actually has the most impact is the value choices we make. It depends on the magnitude of risk aversion in the population. That has more effect than the effectiveness of the intervention. So therefore, we also need to handle how the value choices influences what we actually rank as best or worst. So yeah.
So that comes back to this question of consumer preferences and expectations and so on.
Yeah, because
That's
if you just by
just
varying
a third
the
dimension of outcomes. Sorry, go ahead.
Yeah, so just by varying the gradient, because we applied what is common in the literature, the Arrow-Pratt utility function. If we vary the R coefficient from 3, which was the standard numerical measure they used in the literature on this, so we didn't want to be too far off from what they have done earlier. But if we lower it to 1, close to 1, then the financial protection is reduced to 1/3 in average. And that is something which I think needs to be explored more. Yeah.
Till, Dean, you want to come in on any comments, questions?
A couple of comments.
Yeah.
As a practical matter,
Yeah. Move a little closer.
I think it was Yukiko that raised the issues of much greater demands on empirical understanding and data. And that's absolutely true. I mean, it's overwhelmingly more difficult to do these, not conceptually. It's a little more difficult conceptually. It's a lot more empirically. We need to live with that. There are a couple other things like discounting and so on I feel very strongly about. Maybe we can talk about later. The issues that Mark raised about, I think, two very related issues. ECEAs for interventions that have major impact outside the education sector, outside the health sector. So primary education has important effects on health, but on many other things, water and sanitation, likewise. Can we look at the financial protection benefits of those in terms of reducing risk of health expenditures later? The answer, I think, is absolutely yes. We could do that. They're not measured in market, so if we were going to do a benefit cost analysis, we would want to try to provide the dollar value estimate of those benefits, add them elsewhere. So it relates to your question then about benefit cost analyses. And that leads me to respond around my conception of why we're doing ECEAs really rather than CEAs or benefit cost analyses. And it's because I think an ECEA, by looking at the consequences along the two main dimensions of the objectives of health systems, to improve the distribution of health outcomes and to improve the distribution of financial risk. If those are the two main objectives of health systems, then what ECEAs are designed to do is look just at how well the systems are doing on meeting those two principal objectives. But that doesn't rule out doing benefit cost analyses, and clearly in some sense we need to do benefit cost analyses to be incorporating interventions outside the health sector that influence health and to compare consequences in health with consequences in investments in dams and education and rural roads, which leads to my final comment, which relates to Toby's observation about, well, does this make any difference at all because we have the same, we end up with the cost effectiveness ranking anyway. Well, I give two responses to that. First, part of my agenda here around particularly interventions in high mortality, low income environments is to conclude, if we conclude, that actually we should just be doing cost effectiveness analysis because the financial protection numbers are so small relative to the importance of the health side, and a benefit cost analysis, if you do it crudely, would suggest that here, that you don't really need an ECA and it's a lot more work, so forget about it. But I think that's on the other side of our analysis rather than on this side of our analysis, and that the BCAs the ECEAs will turn out to be more important in places where there are relatively small health consequences for very expensive interventions, health consequences that might well be, from our perspective, worth buying. I mean, I take my set of cardiovascular disease prevention pills very faithfully, that is 5 days a week. And I think it's worth it, but it's not buying a lot of health. The financial protection benefits could be a lot larger, relatively speaking.
Okay. Till, do you want to add anything at this point?
Wasn't directed so directly at me, but of course the intrinsic disadvantage of cost-effectiveness analysis, that it doesn't offer an intrinsic criterion of what we should normatively do. I have a question to specialists in CEA, which has always bothered me and is related to the discounting question. So we're discounting costs, we're discounting health gains, and now in order to come up with a criterion for whether we should or should not do an intervention, we dichotomize across a threshold that is per capita income, 3 times per capita income in a non-discounted way.
Okay, I can't resist one quick comment from my side, which is just on Dean's comment that we may learn that we don't need ECEA, we just can go back to old CEA. Let's just remember, so far we're looking at a set of interventions with very large population health benefits and relatively small financial implications in a macro sense, and there are a lot of other interventions with very large economic consequences and relatively small population health benefits. So we are almost out of time. How many people are standing there? 4? 3. Okay. I am going to suggest we give the last three standing a chance to make their comments, and that we end there. And anyone who wants to hear their thoughts of the panel can do so over a drink and a snack or whatever we're going to be having. So let's go ahead. Please introduce yourself.
My name is Christina Unerheim. I'm an MD PhD student from the University of Bergen and also a visiting researcher here at the HSBH. My question is regard to the question you raised, Chelana, on whether we sort of should look at financial protection or saving more lives. And I think it's more a general comment than that I necessarily expect you to answer it. But I think linking the discussion we had earlier this morning on whether UHC should be a goal or a mean, I think we also have to look at the discussion currently at the global level on the post-MDG agenda, because we know that UHC is on that agenda, it's being discussed, but is UHC a goal, or is it more a mean towards development in general? So when we sort of discuss what also our goal should be when we look at health, we also need to look into whether we actually want health results, or we want health results because we want other results.
Okay, thank you.
Ritu Sadana from WHO Geneva. Just thinking about coming back to the morning's discussion on when the box was presented. And I think
the box.
Yes, and many people
remember the box?
critiqued and constructively discussed that. But just thinking the discussion we had after lunch and now, given the broader determinants of health and what another WHO commission tried to articulate is that it's those broader determinants of health that actually contribute to the inequities that we see in health. And that perhaps those things where we know certain interventions that are outside of the UC box because they're not really under the control of the health system, although that boundary may be different in every country, that there's certain best buys. Maybe, for example, early child development programs, which include a component of health, but also others. There's lots of high-income countries that offer this and they finance it, like in France. But there's also countries like Chile and Brazil who've put a lot of investment in trying to do that. So this session was about financing and ensuring a reduced burden in finance. But there are some issues, some interventions that are really not necessarily within the health sector. But then there's others which we could consider are very much within the health sector, and thinking to the inspiring talk that Dean Frank gave this morning, that underline generational solidarity, which may not feature at all in any kind of cost-effectiveness or even extended cost-effectiveness analysis. For example, palliative care or certain aspects of long-term care for the elderly. but underscore this generational solidarity. And I'm just concerned that if we go to looking at things like the 200 items in Mexico or the 250 items that I think we were talking about in Thailand, that there needs to be some spread in understanding what's actually included. And certainly, they're not fixed over time. You have an opportunity to revise and expand based on people's expectations and preferences. But just to add that into the discussion.
Okay, thanks, Ritu. Dan? You've strategically positioned yourself
Yes,
as
indeed,
the last
to get the last
speaker.
word. So I think Gita, who said that she's worried when an economist starts talking the way she thought some people were talking here, this may be an area where one doesn't want to go. Gita was identifying for us an area in which we feel some nervousness, where we're talking about dollars versus lives, and maybe the dollars are more important. The picture that I get is, coming from Till's talk, is, look, what if we took all that PEPFAR money and just forget about AIDS, just started giving payments to families with the same amount of money and telling them to invest this or, train yourself, maybe there would be gigantic returns because these people are so poor and it's so much money. And maybe that would, in terms of what they value, it would dwarf, the value they place on the lives of those who would die as a result. And that makes us all nervous, I'm sure. At least it makes me nervous. But I'd like to talk about the first case. This is a personal thing. The first time that it actually dawned on me that this trade-off might be something that has to be taken very seriously. And it occurred during a series of trips to Thailand that Dan Brock already mentioned earlier. Tessa and Ula and Dan and I were all part of this group that went to Thailand over a period of several years to talk about financing dialysis. And what we found was that the families that had somebody who had the end-stage renal disease had just the most horrible dilemma in front of them. There was no assistance from the universal plan, and they were paying out of pocket. They spent all of their money, and then they called all their relatives and tried to spend all of their money until the relatives wouldn't answer their calls anymore. Then, finally, whoever it was who was the patient, dad or granddad, whoever, they died because they couldn't afford dialysis another month, and that was the end of them. And then what happened next was the whole family, everybody whose money they spent, is now relegated to poverty, not only now, but for the next generation and maybe even beyond that. There was no hope that they were going to crawl out of poverty. And so, and what did they get for it? They got an extra month or two. So when we talk about lives, deaths averted, as opposed to, counting up the number of adjusted life years, what do we say about the person at the moment of decision here? If grandpa dies if we don't buy dialysis another month or something like that. It looked like the best thing to do, I mean, I reached this judgment, I was sort of horrified when I did, they should just die. That was better. Rather than take the whole family down into poverty so they could eke out a few more months on this planet. I mean, we can protest that they should be in this situation, and of course we should. But if we put blinders on, we just say, what's the best choice given the choices that they actually have here in front of them? The worst case seemed to be spending down all the assets of the immediate household and any relatives' assets that they get their hands on to eke out a few more months of life. And it was unavoidable that they make this choice, as horrible as it is. So I just thank Dean and all the panelists for taking the discussion into this realm, as disturbing as it may be. It's something we do have to think about.
Yeah, exactly, Dan. Thanks for that. On that light note, we will call, because tomorrow will definitely be more optimistic. So thanks the panelists for their presentation.